Hello again. I'm Phyu Aung. I'm associate professor of dermatopathology section as well as the director of oncology surgical pathology fellowship program at MD Anderson Cancer Center in Houston. Today I'm going to talk about practical approach in diagnosis um, of cutaneous melanocyte lesion. And before I start, I would like to thanks again all of you for being here today with me in this virtual meeting. And again, thanks to all the organizing committee member for giving me this opportunity. This is a really great honor for me here today. So let me start the talk about this particular approach in melanocyte deletion. So this is the outline of my talk. So I will mainly focus on giving you the clinical and histopathological features of that melanocyte deletion, which we commonly see, and then some of the borderline cases we need the ancillary study, mainly immunohistochemical study and a few molecular study, and some of the real case review of a number of common and challenging cases. So let me start with a little bit of introduction. So in 2021 in US, the melanoma of the skin represent 5.6% of all new cancer cases. The incidence has been increasing approximately 3% per year. So that means we are getting more increased number of skin biopsy with the melanocyte lesion. And some of the lesion now show more gray area or borderline area. That means like difficult to differentiate, is it benign nevus or the more malignant lesion of melanoma? So that because of those challenging lesion and more increased number of the biopsy cases or the pathology case number, the number of the medical legal problem has been increasing in US too. So majority, approximately 90% of melanoma originate on the skin, but as you know, it may arise from mucosa area as well as conjunctival or leptomeningeus area. Again, those are rare, but it can happen. And then most of the melanoma cases arise de novo, but some may be associated with pre-existing nevus, can be conventional nevus or the dysplastic nevus. So this is the basically clinical diagnosis of the melanoma, right? So melanocyte lesion. So for melanoma, usually you see this asymmetry of the lesion as you see in this figure, right? And then also the border of the lesion is usually irregular, and color, of course, different in like more darker and more brown. And then diameter wise, usually the magic number is 6 millimeter. If more than 6 millimeter or progressive change in size, that's more favor or malignant lesion than the benign. And then the last, that's when we use the mnemonic of A, B, C, D, E. And then E represent the history of change in that lesion, like gradually increasing, change in color, change in shape, etc. So for the medical student and the resident, so A, B, C, D, E is the mnemonics to remember the diagnosis of melanoma clinically. In terms of histological examination, as you know, the gold standard for diagnosis of melanocyte lesion is the H&E histology examination. So in histology examination, the area that we have to focus to differentiate benign versus malignant is the architecture, is the symmetry, or the border, well circumscribed or not, cytology, atypia presence or not. And then in the epidermis, we have to pay attention that proliferations of melanocytes are confluence or not. Is there any pegydoid extension to the granular layer? Or the pattern of growth, mainly nested and well-nested or predominantly single lentiginous growth pattern. In the dermomelanocyte, of course, we have to pay attention maturation pattern. That means the top melanocytes are more nested and the more epithelial, and gradually it became more smaller, and at the end it looks like almost lymphocyte. That's so-called maturation pattern with dermal descent. The other one is host response. It's basically the lymphocytic infiltrate. Even the host response is symmetrical lymphocytic response, or only one side has more lymphocyte and the other side doesn't have it. So the symmetry of the host response is also important. And finally, mitotic figure in the dermomelanocyte, right? So here is a summary, this distinguishing nevus versus melanoma, the size, more or less, more or large, but kind of the magic number is 6 millimeter. And again, symmetry and circumscription, whole response, and confluency. And other thing is presence or absence of ulceration. That means lesion associated, not trauma related, okay? And then growth pattern, and the presence or absence of maturation, just I mentioned, and of course, necrosis. Necrosis is obvious histologic features of malignancy. And those are the features that help us to differentiate benign versus malignant lesion. And the next one is the worrisome histology features, of course, asymmetry, poor circumscription, presence of cytology atypia, and the presence of multiple phenotypes. As I mentioned in the previous talk, like some of them is epithelioid, some are more nevoid. So you have various morphology that means more, can be more malignant than the benign, and predominant of single cell, especially in the junction. That's also not a good sign, and presence of vegetoid upward migration, and something called epidermal consumption or zipper effect, like that here. As you see, the dermis and epidermis separated because the junction is not strong enough because of the malignant melanoma cells. So the keratinocytes are basically attaching each other. They cannot do anymore. So that's another worrisome histology features for malignancy. So, and already mentioned about that lack of dermal maturation. Other worrisome features are include expansine growth pattern, that's we call puffy shed. I will show the picture next one, and presence of mitosis, especially atypical mitosis, numerous number, and presence of ulceration or a presence of regression. As I mentioned in the previous talk, the definitions of regression. So remember, you don't need to see all these worrisome features, something to call melanoma. Of course, it depends. You have to correlate with clinical pathology parameter. So this is some of the example of worrisome features. Presence of necrosis, as you see here, that's worrisome, and cytology atypia very prominent with mitotic activity. This is something we call it puffy shed sign or the expansine growth pattern. This is more favoring the malignant portion. And then the last one is the presence of ulceration, and then presence of mitotic activity. And I mentioned that the size, right? The benign usually small, malignant usually big, but it's not always a reliable feature. You see, this one is the big, okay, so that's why melanoma, that's fine. But here, this is relatively small. If you see the higher power of that lesion, you see how atypical it is with the mitotic activity. So even this is small, that's still a melanoma. So not always like perfect, you know, in I'm going to talk a little bit about the histology features of the benign nevus, right? So let me start with the nevus with congenital features. So usually, if you call something, it should be present since the birth, or it's at least developed during the childhood, not like the nevus, it appeared at when he or she was like 75 years old, right? To call something congenital. So basically, congenital nevus is clustered around the vessel or underneath the structure or around the pilar aortic muscle, often placed singly through the collagen, as you see here. So the main thing is to call it benign, you see the maturation is down medicine. As I said before, the superficial portion is more epithelial and gradually smaller in size, and at the end it became a very small lymphocyte-like morphology. So the maturation is maturation with down medicine, so gradually smaller in size. And the second one is the another features of the nevus is the presence of symmetry, both sides, and inflammation or host response is very minimal or no, and no stromal response either. So those are the features of nevus. On the other hand, melanoma, what you see is asymmetry. You see these vegetoid melanocyte to the granular layer, and then of course these stromal response. You see these pigment incontinence, fibrosis, inflammatory infiltrate. Those are the features worrisome for melanoma. Let me give you the example to go forward. So it's a 55 years old female with a scalp lesions of unknown duration. As you see here, on low power, we can appreciate these compound melanocytic lesion with some kind of congenital-like features going around the adnexal structure and even this hair shaft. So, and then when you go high power, again showing a little bit more congenital nevus-like features. So far we are not sure. And then so based on that, is that melanoma or nevus, right? Let me go back again. It's the only thing is kind of expansine that we don't want to see. And cells are more or less small, but not completely small, and with some kind of congenital feature where some of the area even show the pegydoid spread. So overall, this has both nevus and melanoma features. So those cases on histology ground alone, we cannot be sure. So what we have to do is we have to look at the again high power, and then high power now showing the kind of consumptions of the epidermis and some of the mitotic activity. Right, cells are some of the cells show the prominent nucleoline. So we started seeing the atypical feature and mitotic activity, even though not atypical, even in the deeper aspect. And as I mentioned before, it also shows some congenital nevus-like features, right? So cytology, atypia, congenital features like congenital nevus-like features, mitotic activity, and cells are not that small, and nevus is more prominent nucleoli and showing atypical. So now we have both histology features of benign and malignant. So those cases that we call borderline melanocytic lesion, it show overlapping features, histology features of benign and malignant. So those cases, immunohistochemistry may be helpful. So let's see what kind of immuno we should do. Okay, so, and then after that immunostain, we can favor benign or we can favor malignant. And sometimes even after immunohistochemical state, stay difficult to differentiate. Those cases, we will go further step called molecular study. Okay, so let me go this one. So in terms of immunohistochemistry, as you know, we have different types of immunohistochemical study used for melanocyte deletion, but I'm going to focus on the one that we usually use at MD Anderson. So let me start with HMB45. It's a glycoprotein. Fairly specific for melanocytic differentiation. The best use is to show the maturation pattern. So as I mentioned before, histologically, we can appreciate the maturation pattern. Also, HMB45 highlight the maturation pattern if there is any. That means only the greater reactivity at the top compared to the deep aspect. And then if this is the nevus with a good maturation pattern, if this is melanoma, it can show patchy as you see here, or it can show diffuse. So this is like maturation. Only the top portion show HMB45 expression, but other exceptions of diffuse expressions of HMB45 in addition to melanomas include blue nevi, Spitz nevi. They can show diffuse expression. So don't. It can be a pitfall. And then, so in Spindel's shade melanocytic lesion is diffusely positive for HMB45. It is most likely to be benign. So that's a good kind of fact that we need to know. So here I'm giving you the example of HMB45 state. We have it, the melanocytic lesion. Here you see how nicely highlighting the maturation pattern just at the top, and also another example. So top part of the melanocytes are positive for HMB45, but gradual loss without medicine. That's it, highlighting the maturation pattern. And another one, blue nevus. As I mentioned before, even though diffuse staining with HMB45, those are not melanoma, those are just blue nevus, can be positive diffusely. In melanoma, it can be diffusely positive like this here, or it can be patchy like this. So that's for melanoma HMB45 staining pattern. The next one I want to talk about is the MAD1 Ki67 double immunostain that we use. So for nevus, so here the red color is the MAD1, and then the brown nuclear staining is the Ki67. So the upper portion is the melanocyte highlighted with MAD1 red stain, but you don't see any Ki67 in those cells. On the other hand, for melanoma, the melanocyte highlighted with MAD1 show proliferated activity with Ki67. So this is the melanoma case. So the double staining is helpful because if you did only Ki67, sometimes you are not sure those are in lymphocyte or melanocyte or even the endothelial associated with melanocyte. Okay. Another one showing that MAD1 Ki67 double stain in the benign or nevus stain. So you see in the dermal component, in the epidermal component, of course, as I mentioned before, epidermis always the cells are proliferating. So it's not surprising to see the proliferating or Ki67 positive cell. But in the dermis, the melanocytes are purely just MAD1 staining with red color, and we don't see any or very low nuclear staining with Ki67. So that's favor the benign over malignant melanoma. So here is the malignant melanoma with the MAD1 and Ki67 staining. You see how many of those cells are showing the double expressions of MAD1 in the background with brown, and then black nuclear staining with Ki67. So high, very proliferated rate in this melanoma case. So the other question usually people ask is, how much proliferation is too much by Ki67? So in the literature, they provide different cutoff as you see here, but in general, more or less, the nevus should be less than 1% proliferative rate, and dysplastic nevus, it can be up to 5%, and Spitz nevus can be up to 10%, and melanoma should be more than 20%. Again, this is very subjective, and you have to put together with clinical and other histopathologist parameter. Okay. And the other relatively new immunohistochemical stain that we can be using in melanocytic lesions are called PRAME. So the PRAME is the melanoma-associated antigen. So a member of this is the member of family of cancer testis antigen, CTA, is an attractive target for immunotherapy, not only for the diagnosis of melanoma versus nevus. Okay, so and also it's an important biomarker for metastatic risk in class 1 UVA melanoma cases. So it's also the prognostic factor and therapeutic target. as well as can be for diagnostic targets. So it's pretty good marker, but keep in mind, this is not specific for melanocytic lineage. It can be posited in various non-melanocytic malignant neoplasm, including non-small cell lung cancer, and as well as the breast cancer, renal cell carcinoma, ovarian carcinoma, as well as the mixed white liposarcoma, etc. Okay, so nothing is 100% perfect. So in terms of staining, melanoma should be diffusely positive. More than 75% of those cells should be positive with PRAME. It has been reported that approximately more than 80% of metastatic and primary melanoma cases are diffusely positive for PRAME. And then cutaneous melanocyte, up to 86% of cases are completely negative, and focal positivity in the 14% of dysplastic nevus or other acquired nevus, including splits and the traumatized nevus. So let me show you the example of PRAME in the so this is the same lesion. And you see that this fragment show nevus cells, and the other fragment show melanoma with the background stroma response, pigment incontinence. And when we did the PRAME, so the PRAME here you see in that nevus component, what you see is purely negative, right? So these small nevus cells are purely negative. On the other hand, the in situ component overlining the nevus cell, as well as invasive component on the other fragments, are all positive. So nevus cells are negative and melanoma cells are positive. So back to our case that we mentioned previously, that case have shown in both benign and malignant features. So here HMB45, kind of diffuse in low power, but when you see high power, you see the difference in expression pattern. Some are diffusely positive, some are kind of, this is stronger and this is weaker. So variable in the intensity of the staining. So it is not showing the maturation pattern as we see in the nevus cells. So that's not a good features for benign diagnosis. And another one, this is a double stain with MOD1 Ki67. Again, what you see is a lot of proliferative rate as well as PRAME was positive in these cells. So all put in together, this is the melanoma, even though it is relatively small nevoid cell, this is nevoid type melanoma. So that's what I mean. Borderline cases, you will need the ancillary study, such as immunohistochemical study. So in terms of nevoid melanoma, it was the first terminology was introduced in 1985, but still a lot to explore more about their pathogenesis and etc. Histology clue is, as I said, expansine growth pattern, and then large dominance with looks like on H&E you see might be the maturation, but not the real maturation. Of course, mitotic activity, especially in the D aspects of the lesion. So those are not good for the benign nevus. So H&E, and if we are not sure about that, we do an ancillary study. HMB45 usually show patchy intensity or can be diffuse, and is failed to show any maturation pattern by HMB45 and high proliferative rate with Ki67. Also molecularly, if you do any chromosomal study, it will show the abnormal copy number on chromosome 6 or 11. On the other hand, mitotically active nevi are not showing those abnormalities. So the next step, if you are not sure, you can do the molecular study. This is a follow-up for that case. And unfortunately, the patient already have the sentinel lymph node positivity. So this kind of confirm that this is the nevoid type melanoma, not really the nevus. Okay, so immunohistochemical study, just a summary to differentiate benign versus malignant melanocytic lesion. HMB45 nevus will show maturation pattern, and then melanoma will show patchy staining pattern. And then HMB45 can show be diffusely positive, especially in the spindle shape, such as blue nevus. And MOD1 nevus is usually diffusely positive, and melanoma is usually patchy positive. And Ki67 high in melanoma and low or absence in nevus, and PRAME is negative or focally positive and diffusely positive in melanoma. Okay. So another thing is sometimes we use the immunohistochemical study just to see is this really melanocytic lineage or not, because on histology ground alone, sometimes difficult to see especially if it's not pigmented, right? So when you use that, make sure there's a potential pitfall of using those immunohistochemical study. So these are the common marker to use the diagnosis of melanocytic lineage. So we use HMB45 as I mentioned before, MUD1 as I already mentioned it. The other thing is the thyroxinase, and other is 100, SOX10, and MIDF. So these last three, S100, SOX10, and MIDF, are mainly very useful for the desmoplastic melanoma. Okay. So MUD1 is basically melanoma antigen recognized by T cell. It's a cytoplasmic staining, sensitive but not very specific. It can also label the macrophages. So I don't know if you have already listened to my other talk in the sentinel lymph node. If you see MUD1 positive cell, if you are not sure, you can do HMB45 to differentiate are they melanoma cell or are they macrophages. So that's what is mentioned in here. And then another important use is it can be diffusely positive in spindle cell or desmoplastic nevi. So spindle cell melanocytic lesion, if it is diffusely positive by MUD1, most likely benign, or mostly negative in malignant spindle cell melanocytic lesion. Okay. So here's the example. So sometimes this is another pitfall. This is a very sun damaged skin. As you see here, here's a solar damage. And then when you do the MUD1, you see how confluence is there showing that. So this is like kind of overstaining, especially in the sun damaged skin. So be careful, don't call this is a melanoma inside you, even though it's staining kind of confluence, even a little bit of petitois. This is overstaining. So MUD1 can be overstained in very sun damaged skin. Keep in mind, this is one pitfall. Another pitfall is we already mentioned that MUD1 expression in the macrophages, as you see here H&E, and then here as you see multinucleated cell with the melanin pigment. Those are staining with MUD1, and CD68 highlight that those are the histiocyte, not the melanocyte. Other thing that it can be useful is S100, especially for spindle type, spindle shape cell in spindle cell melanocytic lesion. Sorry. So S100, one pitfall is it can be not only in the melanoma or melanocyte, but also positive in dendritic cells. So when you use S100 in the metastatic melanoma to the lymph node, it's very, be careful. Let's say like this, don't overcall as a melanoma, right? For this one is obviously you can see both melanoma cell as well as the dendritic cell highlighting with S100. Right, so if you don't have that and only this, and then you call this is a positive lymph node, that will be overcalling it. So be careful, S100 can show the dendritic cell positivity. So here we don't usually use S100 because it's non-specific for melanocytic lesion, because as you know, it can be positive in the neural lesions such as MP and ST, right, malignant peripheral nut-shaped tumor. Next one for pitfall of S100 is the here in the scar. This Schwann cell in the scar can be positive for S100. So don't make mistake with this is the residual desmoplastic melanoma, right? These are just non-specific staining in the scar by S100. Most likely those are Schwann cell. Other thing that we use in the melanoma especially in the spindle cell melanocytic lesion, because you know the desmoplastic melanoma, the regular melanocytic markers such as MUD1, thyroxinase, HMB45, they can be negative. Only the S100 and SOX10 can be positive. But S100 and SOX10, as you know, those are also can be positive for neural lesions such as neurofibroma or MPNST. So if you need to differentiate MPNST versus desmoplastic melanoma, MITF can be useful. So it's just showing the MITF staining in the melanoma in situ component, and also it can be positive in the histiocyte and fibroblasts, as you see here in the damage. So don't misinterpret these cells as a melanoma cells. Okay, so MITF is non-specific, but it can be useful for the desmoplastic melanoma if you want to differentiate from neural tumor. So marker of melanocytic differentiation, as I mentioned, it can be useful in diagnosis of melanomas and other melanocytic lesions, especially borderline cases, which show both histology features of both benign and malignant melanocytic lesion. But keep in mind, it can be lost in melanoma, especially when the alteration in morphology. And again, sometimes loss of differentiation. So the previously, especially now we see more common this loss of differentiation after treatment with immuno or targeted therapy. Obviously, epithelioid primary melanoma, all the sudden in the metastatic site is become spindle shape. So that if that changed morphology, also change the expression pattern of the melanocytic marker. And the other thing is not only losing the melanocytic marker, but also can show the aberrant expressions of other markers, such as keratin, neuroendocrine marker, and desmin. So always be careful not to misinterpret, especially in the melanocytic lesion with alteration in morphology or loss of differentiation. Okay, let me move to a case presentation. It's a 50 years old male with a pigmented lesion on the forehead, and clinical impressions was rule out lentigo maligna versus solar lentigo. So here in low power, one can appreciate hyperpigmentations of basal keratinocytes here. And then here in the high power, again, highlighting the hyperpigmentations of basal cells. It can be melanocytes or it can be melanocyte. We cannot be sure. So here we did the MUD1, sorry, this is the pan-melanoma cocktail, including HMB45 and thyroxinase. You see there are some of the cells are staying with that. Also, you see these dendritic cells are positive. So based on that, are we going to call this is melanoma in situ or not? So the differential, of course, include melanoma in situ or just the solar lentigo or pigmented keratinocyte. This is the pigmented keratinocyte, pigmented actinic keratosis. Because if you go back, these cells, only the nicely staining, these are the real melanocyte. In between, these are just dendritic cell. So it's not really confluence. So that's not meet the criteria for melanoma in situ. And next one example here, you see another positive melanocyte at the dermal epidermal junction is some regression here. And here is another adjacent area of the same lesion, kind of similar to what we have seen the previous case, and another highlighting with the pan-melanoma cocktail, HMB45 and thyroxinase. Again, even though we still see these dendritic staining by this pan-melanoma cocktail, also we are seeing some of the real cell here, kind of confluence here. But if you want to make sure, you are not sure is that all melanocytes or most of them are dendritic cell, just the pigmented keratinocyte, you can do the SOX10. This is nuclear staining, so a little bit easier to see. Now you see not only the single cell at the dermal epidermal junction, it is highlighting the peptide spread as well as the nest. So both containing both nested and single cell kind of confluent growth pattern, and these are the criteria for melanoma in situ. So this is in situ melanoma. Another case, a 74 years old male with a 1.5 centimeter lesion on the neck. The patient has a history of multiple dysplastic nevi and 2 previously diagnosed melanoma on the face and the scalp. Here's the high power. So having this kind of history, we already bias that most likely the patient might have a melanoma, right? So here is the high power. You see here, this is we know keratinocyte, but here with more epithelioid cell with kind of clear or more amphiphilic cytoplasm, and then it's high power. Here see kind of a nest like growth thin, these clear cell changes along the annexal structure. So this is worrisome features. So we is this melanoma in situ with annexal extension or something else? Right here, another focus showing these kind of nested like then even the looks like peptide spread like area. So you see nested is mainly in melanocytic lesion. So is this melanocytic lesion? If it is so, with this kind of annexal extension, has to be melanoma in situ, right? So again, the follicle is completely replaced by these glial cells. So again, this is extensive annexal extension. So it's very worrisome. Some people even might think this might be the invasive component right here. So seeing these two, it can be definitely melanoma, at least inside you with annexal extensions or even the invasive melanoma. So what is the, here we did the immunostain pan-melanoma cocktail that include HMB45, MUD1, and thyroxinase. You see very few melanocytes are highlighted with PAML. And then we look at, again, we repeat the PAML just to make sure. And then here SOX10, because, okay, it's a really, because it's really worrisome. So this is one area, and SOX10 is almost negative, and another area, again, SOX10 is not confluent enough. So altogether, this is just the squamous cell carcinoma with clear cell changes instead of melanoma in situ with the annexal extension, right? So be careful, especially with the history of multiple melanoma and dysplastic nevus, and then histologically kind of nested with annexal extension and over calling it as a melanoma. Actually, it was a diagnosis of squamous cell carcinoma with annexal extension. Next one is a 90 years old male with a forehead lesion, and patient has history of non-melanoma skin cancer. Here you see the nodular, very lesion infiltrating into the subcutaneous tissue in high power, showing the CD10 positive in those lesional cells. And again, it's showing some of the pigments, right? So it's worrisome for melanocytic lesion here, and we are looking at S100 positive, MUD1 positive in the dominant cell, also in the genital cell, and then MITF is also positive. So what can it be? It looks like melanoma, right? We have pigment, we have the all melanocytic marker are positive. So diagnosis melanoma, right? So melanoma can be positive for CD10. So keep in mind, because as you know, CD10 is usually for AFX, right? Atypical fibroxanthoma, but it can be positive in melanoma. So not only showing CD10 is not specific for AFX, it can be shown as an aberrant expression in melanoma. So other CD10 positive cases can be seen in spindle cell sarcoma, angiosarcoma, and myofibrosarcoma. So be careful, CD10 is not sensitive and specific marker for AFX only. It can be positive in other malignant tumors such as different sarcoma. And according to this paper, approximately 53% of primary melanoma can be positive for CD10, and 75% of metastatic melanoma can be positive for CD10. So another one is that AFX is always negative for metastatic melanocytic nevus or melanocytic lesion. So for that one, AFX is not always negative for melanocytic, because as I have mentioned before, melan A or the MUD1 can be positive in AFX, especially in the giant cell or other histiocyte. So it's not always negative in melanocytic lesion. And then the other thing is S100 negativity, right? Because the scar that I just showed, S100 can be positive in the background dendritic cell in the lymph node or the Schwann cells in the scar area. So nothing is like 100% specific. So keep in mind, these are the pitfall of immunohistochemical study, just showing the MUD1 staining in these very atypical cells in the AFX. Okay. Let me talk a little bit about borderline melanocytic proliferation. So as I already mentioned a little bit about that, the lesions they show overlapping histology features of benign and malignant melanocytic lesion. Those cases, we can do the additional immuno, as I mentioned before. Even after doing those immunostains, some of the cases can show overlapping immunohistochemical features of benign and malignant. So not only histology, but also the immunohistochemical features. So those cases, we might need a molecular study such as FISH in making the definitive diagnosis of extremely difficult borderline melanocytic lesion. But like we use this like in less than, I would say 3% of our melanocytic cases, we need to do molecular studies such as FISH. So mainly here we use FISH in terms of molecular study. So let me give you the example. 9 years old girl with a pigmented nodule on the right upper neck. Here you see in low power, compound melanocytic lesion, kind of small, looks like the maturation pattern in low power. In high power, again, the cell in the upper dermis are more epithelioid and larger, and gradually the size is decreasing. So this basically the kind of seeing the maturation pattern that I mentioned before. So based on the low power, this looks like nevus. Okay, and then in high power, you started seeing the mitotic activity as I highlighted here, even in the deeper aspect of that. So I just worry about it. Oh, even though this is showing maturation, is that pseudo maturation? And then the other factor in your mind is this is the kit. So I did the usual HMB45. You see kind of patchy. Some of them show strong expression. Some of them is weakly or almost negative. And MUD1 and Ki67 show some of the cell co-expressions of MUD1 and Ki67, highlighting the high proliferative activity. So worrisome immunohistochemical study, right? Features, I mean. So, and I also did the P16, and then you see like the fuse loss of P16. This is again worrisome for malignant lesion, but the age of the patient is staying, and then the morpho-histologically showing so-called maturation patterns. So it's showing both benign and malignant features again. So we did the FISH assay. So let's talk a little bit about FISH. So what is the FISH? Now we are using the 5 prot, including RREB, CDKN2A mix, CCND1, and the as control is the centromere 9. So, but keep in mind, whenever we do FISH, it's just to complement the histology assessment, not to go against the histology assessment. So main thing is the main gold standard is the histology examination. When we see borderline cases, as I mentioned before, we can go for ancillary study. Again, those ancillary study can just to complement, not to go against the histology features. So with our current understanding, negative fish research should not be used to negate the histology impressions of melanoma. Let's say you think of melanoma and you do the fish and fish show the fish positive, that mean favoring malignant melanocyte deletion. Of course, that's good for you. It supported what you think based on the histology or the immunohistochemical feature. But let's say you are pretty much sure histologically and immunohistochemically the melanoma, but fish is negative. Can you go against your histology assessment? No. So keep in mind, fishes only complement the histology assessment. Should not be used to negate the histology impressions of melanoma just by seeing the negative fish result. Okay. So our case, as you see here, there are positive fish showing at least 4 out of 5 parameter are more than the cutoff values. So the best diagnosis for this case is nevoid melanoma of childhood, even though relatively young, even though showing the maturation pattern, the immunostain and the molecular marker with fish show the malignant feature. So altogether, combining this is the nevoid melanoma of childhood. Next case, 11 years old boy, pigmented lesion on the leg. You see here the shear biopsy and some fibrosis at the background. Let me show you the higher power, some of the nest, or even show the some of the multinucleated cells like morphology, a little bit of fibrosis. Most likely this lesion has been traumatized. But cells are not so benign looking because you see the prominent nucleoli large, and then the stromal response as well as the host response called the lymphocytic infiltrate. And this is the P16. You see almost all of the, we have three pieces only focus at the periphery are showing P16 positive cells, and then the rest all are lost or P16 expression. So this is showing very worrisome. And SOX10 highlighting all these melanocytes, including the multinucleated cells like area with background fibrosis and stromal response. And Ki67, this is the outside submitted case, so we couldn't do the double stain here. This is outside did only pure Ki67, but you can appreciate some of these big nuclei of the atypical melanocytes are positive for Ki67, showing a higher proliferating rate. And HMB45 showing patchy expression, some are stronger and some are weaker. We don't see any nice maturation pattern with loss of HMB45 expression with downward descent. This is the MUD1 Ki67. We did it here. And then you see the double expressions of MUD1 and the Ki67 expression, even in the deeper aspect of the melanocyte. So putting together, it's very worrisome for the malignant melanoma, but the patient is only 11 years old. So this is basically space-wide melanoma in the 11 years old boy. So again, even though it is a young age, but based on the histology and immunohistochemical features, this is qualifying for the melanoma. So this is the sentinel lymph node from that boy, and fortunately already positive in the sentinel lymph node highlighted with the SOX10. Here are the melanoma cell on H&E. Okay. So even based on the time limitation, I cannot go very detailed in the space-wide melanocyte deletion, but just for your review when you have a time, these are the criteria that will help you to differentiate SPID nevus versus atypical space-wide tumor versus space-wide melanoma. The example that I gave you is just space-wide melanoma. And this is the immunohistochemical marker, which can be useful to differentiate these three space-wide melanocyte deletion. And this is another molecular marker, which can be, again, useful to differentiate these three things. So in whoever is interested, you can review this slide later. And next case is the 14-year-old girl with a round lesion on the right lower abdomen. Here we have a 2 fragment. In low power, kind of, here is ended with nest, this side, and the other side is not, more single cell. So the asymmetry, you are seeing it. But kind of well circumscribed on low power. In high power, you started seeing cells are arranged in larger nest in the superficial dermis and epidermis, irregularly dispersed pigment. See, there are more pigment on this side, almost more pigment here, and then almost no pigment there. In terms of the lymphoid infiltrate, again, it is asymmetry, mainly focused on this area and almost none here. So the asymmetric distributions of pigment and lymphoid in aggregate is not a good sign. Then in high power, some of the area you can see a little bit of pachydocyte towards the granular layer. And on the other hand, you are seeing the so-called camino body. So camino body is supposed to be a classical features for the benign SPID nevus. But again, keep in mind, nothing is 100%. Just presence of camino body is more favoring benign. So now we are seeing kind of 2 overlapping features of benign and malignant spits, right? And then when you go further, you see the mitotic activity or in the deeper aspect of the lesion. And some of the lesion as well, like this one is showing some cytology atypia with pleomorphism, including scatter mitotic figure. Even though this is not atypical mitosis state, these are mitotic figure in the deep dermis, and you don't see any nice maturation when you see from top to bottom. Okay. So this is just highlighting the mitotic figure. And this is the HMB45 staining. You see the patchy staining pattern, right? The intensity is variable. So patchy HMB and double immunostain showing MOD1 and Ki67, high proliferated cells in the dermis, so not a good sign. So we did the fish, and fish is kind of borderline. That means at the cutoff value, because you see the, so in the cutoff, even though borderline positive, based on the histology and the immunohistochemical features, we are already favoring melanoma. We just want to get the more supported finding from molecular by doing fish. But even though fishes stay borderline, we favor is a space-wide melanoma. Okay. Why do we call space-wide melanoma? Because of presence of cytology atypia, irregular peptidoid migration, no obvious maturation without medicines, and irregular pattern of Ki67 and HMB45 expression, and then the result of borderline fish. Even though it's not real positive fish, but combination with clinical and histopathology features, this is good for the melanoma. Okay. Next one, what I want to talk about is subtypes of space-wide lesion based on the molecular and genetic alteration. So as you see here, we have like 6 different types, but due to the time limitation, I'm going to focus on the space-wide lesion associated with BAP1 loss and BRAF V600E mutation. So let me start with the case. It's a 35 years old Caucasian female, a lesion on the right helix as well as the right posterior shoulder. And the clinical differential was intradermal nevus versus dysplastic nevus. Both of the lesions show similar histology features. So this is one of the representative session. One can appreciate these dome-shaped melanocytic, diffuse melanocytic proliferation in high power. Here, one can appreciate some of the lymphocytic infiltrate as well as diffuse melanocyte. Some of them has the larger more epithelioid. Some of the cells show larger, more epithelioid morphology, and some of them show just more smaller and the nevoid appearance. And when we did the HMB45, it's basically, it showed maturation pattern with almost loss of expression in the dermis, just highlighting the junction and melanocyte. And again, here is the double staining with MOD1 and Ki67. What we are seeing is only the MOD1 expressing melanocyte with no proliferation rate highlighted by Ki67 expression. So differential was, is that just space nevus or conventional compound melanocytic nevus or the melanocytic nevus with BAP1 loss. So we're trying to do the BAP1 immunostay. Here we can see the internal control of nuclear expressions of intraepidermal keratinocyte by BAP1, but all the melanocyte, what we are seeing is loss of BAP1 expression. And then we did the BRAF V600E immunohistochemical study showing expression of that. That means these lesions show mutation in BRAF V600E. So combination of this BRAF expression, loss of BAP1 expression, and the growth pattern of the melanocytic lesion we just saw, and the patient history of multiple melanocytic lesion altogether, this favor the melanocytic nevus with BAP1 loss. So let me talk a little bit about this BAP1. It's a BRCA1 associated protein. It's an enzyme. The genes is located on the chromosome region 3p12. 3p12, sorry. This is the tumor suppressor gene with a role in cell proliferations and the growth inhibition. So this lesion is important to be recognized because this BAP1 loss of BAP1 expression can be due to germline or sporadic mutation, but both of the lesion, even germline or sporadic mutation, in terms of histology, they show the same. So histologically, we cannot differentiate. But if it is a germline mutation-related lesion, this is the autosomal dominant inheritance disorder with the that will increase the risk of variety of malignant and benign tumor. So the affected individual can develop one or more types of tumor, as well as his or her family member can also have these different types of tumor, including uveal melanoma, clear cell renal cell carcinoma, malignant mesothelioma, lung adenocarcinoma. In the skin is most of the time, those are benign lesions as we see here, but there are always there's an exception. So let me show you another example, 76 years old man with a papular brown lesion on the right cheek. The patient had the lesion for approximately 2 years. Due to the change in color, a shape biopsy was performed. There's no other significant surgical, medical, or family history in this patient. So the patient said that the lesion has been there for approximately 2 years, but due to the change in color, shape biopsy was performed. Here is the one can appreciate these dome-shaped melanocytic lesion, and then looks like the biphenotypic histomorphology. This side is more epithelioid ledger, and this side is more smaller and nevoid. In high power of those two areas, here is again high power epithelioid lesion, and then high power of more nevoid or smaller cells here. And then in the epithelioid area, one can appreciate mitotic activity as well as the multinucleated cells and cytology atypia, including prominent nucleoli. And also, here's an associated host response lymphoid infiltrate. And this is the MUD1 Ki67 staining. This is more epithelioid component. This is more nevoid component. In high power, the epithelioid component show this high proliferative rate, highlighting with the Ki67 expression in the MUD1 expressed melanocyte. And on the other hand, the smaller component of cells are the components of smaller cell show almost no proliferative rate by Ki67. Another one that's the BEP1. So BEP1 in the smaller cell is showing more nuclear expression, and on the large epithelioid cells, we don't see the nuclear expression. Mainly, we are seeing membranous and weak cytoplasmic staining. So this is basically loss of nuclear expressions of BEP1. Whatever we are seeing cytoplasmic or nuclear stainings are non-specific staining. So in summary, the nevoids or smaller cells show retained BEP1 expression and then loss of BEP1 expression in larger epithelioid cells. And we did the BRAF V600E. It showed a mutation in both epithelioid and nevoid cells. So the differential diagnosis is the melanocytic nevus with BEP1 loss, as we see in the previous case, or this is the melanoma with BEP1 loss, or this is the melanoma arising in association with nevus and BEP1 loss. So we did FISH, and then FISH show that we kind of divide the two morphologically distant area, and we found that this epithelioid area show gain in cyclin D1, therefore interpreted as positive. And REB1 and MIP prot is negative, basically, and then also P16 prot is also negative. So both two components of the lesion show similar genetic profile by FISH. So the best diagnosis for this case is the melanoma arising associated with nevus and BEP1 loss. So as I mentioned before, even though most of the BEP1 associated skin lesions are benign, but you can see that rarely see the melanoma cases. So always look for the cytology atypia, mitotic activity, etc. If you need help, please do the immunohistochemical study as well as the FISH if needed. So this is the paper that we describe melanoma with loss of BEP1 expression in patients with no family history of BEP1 associated cancer syndrome. So it's worse, right? Because if you have the BEP1 associated cancer syndrome history, you might pay more attention. If not, this is like pitfall. This is another case from the literature. This is the father and daughter, but this case is patient with a history or family history of this BEP1 associated syndrome. So clinically, it show very well circumscribed, don't shade skin color up to 1 centimeter inside. Histologically, predominantly dermal nodular melanoma. Breast lobe thickness is up to 4.5, and they found the BRAF V600E mutation and loss of BEP1. They did the white local excision, and sentinel lymph node was positive, and according to that report, the patient is stay alive and disease-free for 6 and 3 years, respectively, after the treatment. So the prognostic significance of melanoma arising in this BEP1 associated nevus is still unclear because it is rare and we are still studying, and the more follow-up study is needed to understand the prognostic value of these melanoma cases from BEP1 associated nevus. So this is the example showing BEP1 deficient nevus plus BEP1 deficient melanoma. So summary, well circumscribed, don't shade skin color PEPU could be the first manifestations of BEP1 cancer syndrome. So suspicious lesions should be excited and evaluated by a dermatopathologist or pathologist. Be aware of atypical histological characteristics, especially for melanoma. Evaluate for BEP1 and BRAF mutation because those two are mutually exclusive. BEP1 loss, but BRAF mutation present in these cases. And to identify, by doing so, we can identify individual and family with BEP1 cancer syndrome. We can offer genetic counseling, consider germline DNA testing for BEP1 mutation to prevent or early detections of more aggressive tumor in this patient. So take home message from this talk so far. When you encounter a pigmented lesion, determine first if it is melanocytic or not. If needed, please do the immunostudy. It can be helpful, but be careful about the pitfalls that I already highlighted. And detailed examinations of architectural and cytology features of melanocytic proliferation is needed to differentiate benign versus malignant. If you see the borderline cases that show both histology features of benign and malignant, you can perform immunohistochemical study, but usually do the panel more than one marker because single marker is not always specified, okay? And of course, if you still see the borderline lesion showing not only overlapping features or histology feature, but also overlapping features or immunohistochemical feature, you can go for the molecular studies such as FISH. So remember, another take-home message is not all the criteria are equally created. So you do not need then all these criteria to establish the diagnosis. Avoid bias, always first review the slide and then look for the clinical information, and then you put together clinical and histopathology features. Clinical information may be very helpful, so you cannot depend only on the histology examination. For example, previous trauma, how long it has been, that the lesion is changing in shape or size, or any possible recent changes, etc. So both are important, but start with the histology and combine with the clinical. So the art of diagnosis melanocytic lesion is the ability to combine clinical information with histology features and ancillary studies such as immunohistochemical study. Yes, so the last portion of this talk, I want to talk a little bit about therapeutic targets. So first one, I'm going to start with the BRAF V600E. It's a very common mutation in the cutaneous melanocytic lesion, and this mutation can be found in approximately 60% of cutaneous melanoma. And more than 90% of cases, that mutation represent a single nucleotide mutation resulting in substitutions of glutamic acids for valine, that is BRAF V600E. As you know, the gold standard is next generation sequencing or NGS, but most of the lab, not every lab has the NGS assay. Not only that, in terms of turnaround time, the immunostain, especially in our lab, if we order in the morning, we can get the result by end of the day. So on the other hand, next generation sequencing, it can take a week and more to get the result. So in terms of immuno for this V600E mutation BRAF, we use VE1 clone. So it has the 97 to 100% sensitivity and specificity compared to NGS in detections of presence of BRAF V600E mutation. One pitfall is when we see heterogeneous staining pattern in immunohistochemical study, it can be associated with lack of BRAF mutation by NGS. So in those cases, we have to recommend to correlate with the NGS result. Let me show you some of the example. In this case, we see that diffuse V600E expression in the tumor cells. So this is the positive for mutation. The next case, clearly all negative in the tumor cells. So negative for V600E mutation. And then this is the case that I have mentioned before, the heterogeneous expression pattern of V600E immunohistochemical study. In those cases, we have to recommend to correlate with NGS result. Next one is the related to immunotherapy, PD-L1 immunohistochemical study. As you know, melanoma is considered to be a very immunogenic cancer. So immunotherapy targeting these monoclonal antibodies, including cytotoxic T lymphocyte associated antigen for CTLA4, like example ipilimumab, or targeting programmed cell death receptor, example nivolumab, or PD-1 ligand, PD-L1, example durvalumab. So these are very promising therapeutic targets for the melanoma, especially for patients with advanced stage tumor. So as you know, because of this discovery, one of our colleagues from MD Anderson, Dr. Allison, got his Nobel Prize for this excellent discovery of immunotherapy. So in terms of immunostain, we have an FDA-approved clone for PD-L1, two different types. One is 22C3 and the other one is 28A. So 28A is the one that we use for melanoma cases, and the other one, 22C3, is for other malignant tumors such as lung carcinoma. So in terms of interpretations and reporting guideline, so you have to first specify which clone you use for this immunostain, 22C3 or 28A. In the report, we have to report percentage of viable tumor cell, is that partial or complete in terms of membranous staining pattern, and any variability in the staining intensity. Also, another pitfall is PD-L1 can be posited in normal inflammatory cells, such as lymphocyte, macrophages, as well as necrotic tissue. So those are the pitfall for interpretations of PD-L1 immunostaining. This is just the example of PD-L1 22C3 clone expression pattern. We see no expression or low expressions, and here is like very high expression of the membranous staining pattern. Next one is 28A clone, almost no expression, very few cells expressing, and this is a little bit more than 5 or more than 5% of tumor expressing 28A clone PD-L1, and diffusely membranous staining in more than 10% of the tumor cell. Here is an example of melanoma, here low power and high power. Here's the H&E and representing PD-L1 stain slide, and you see these partial to complete membranous expression with variable intensity of PD-L1 in approximately 90% of tumor cell. So this is the representative section for metastatic melanoma of lung. So here is the PD-L1 expression showing this membranous staining in these cells. So the question we have is these cells expressing PD-L1 are the real tumor cell? So when we did the SOX10 immunostain, we found that the cell that expressing PD-L1 are not staining with SOX10. Here you can appreciate with this red nuclear expression pattern. So by doing this double stain, we confirm that these cells are not, these cells expressing PD-L1 are not melanoma cell, just the macrophages of the lung. So these are the possible pitfall when we do PD-L1, especially in the organ system with a lot of macrophages. And thank you so much again for your attention. And thank you for joining me. And thanks for giving me this opportunity. And if you have any question, I'm happy to take it. Thank you. Bye. Hello. I am Phyu Aung. I'm one of the dermatopathologists at MD Anderson Cancer Center. So today I would like to talk about update on CAP protocol and AJCC accreditation staging parameter for cutaneous melanoma, including how to examine and report clinically relevant histopathology parameters. So first of all, I would like to thank all of you for joining me today on this virtual meeting. Of course, I prefer in person so we can interact more easily, but that's what we have now. So let's try what we have, okay? So I have no conflicts of interest to disclose, and I just wanted to thank the organizing committee member, especially my friend Leslie, for giving me this opportunity. It is a really great pleasure for me to be with you in this virtual convention of Philippine Society of Pathologists. So let's start. So this is the outline, as I mentioned before, how to report melanoma following recommendation by updated CAP cancer protocol and accreditations of AJCC, TNN stagings and classification. I will also go over some of the potential pitfall in histopathologist examinations of staging parameter in melanoma. So melanoma, at least in US, it represents about 5.6% of all new cancer cases. And as you see here, the in US, the incidence has been increasing over the several decades, most likely due to the early detections of this melanoma. People pay more attention to this pigmental lesion, and of course also depend on the environmental factors such as ultraviolet light, etc. So, but good news is the death rate, as you see in this figure, the death rate has been stable for several decades, and then it's most likely because of the effective treatment that's available now, especially for the advanced stage melanoma patients, such as immunotherapy, right, and the targeted therapy. So those are the good news. So let's look at the survival of the patient with cutaneous melanoma. So when you look at this 15-year survival curve, one can appreciate that the survival of the patient with melanoma is directly proportionate to the stage of the disease of that patient. So here, again, showing the 5-year relative survival rate. See, patient with this localized disease that is called early stage or stage 1 and stage 2 patient, their survival is pretty good, almost 100%. All they need to do is just to take out the like white localizations of that melanoma, the localized disease. But the bad news is that for patients who already have the distant metastasis, like the stage 4 disease, you can see how difference is like the 5-year survival rate is dropped to like 30%. So as a pathologist, it is very important to carefully examine all the histopathologist parameters that are relevant to clinical and staging, as of course, which we guide the management of this patient and report appropriately and accurately, right? So for that purpose, the College of American Pathologists are trying to offer the protocol that way that can help the pathologists the relevant information which should be included in the pathology report. So there are two portions: essential element that we have to report and recommended element that we should report. And those are based on these 8 editions of AJCC TNN staging system. So in terms of this cancer template, or that we call synoptic template, is required for accreditation. So for the pathology lab, it is required by the CAP, right? College of American Pathologists. In some of the cancer institutions, those are required for accreditation by the National Cancer Institute. So at MD Anderson, we have been using this cancer template since 2015. So in terms of pathology report, it's very fascinating, right? Because our pathology report became more comprehensive because of improved knowledge of biology and background pathogenesis of the tumor. So now our pathology report not only contains the diagnosis, but also prognostic factor and the mutational information. This pathology report, the information from those reports are very important for clinical decisions and the treatment modalities of the patient with melanoma. So in terms of this is just the general initial surgical management of patient with early stage cutaneous melanoma. If someone is clinically suspected to have melanoma, the first thing we should try to do is excite entire lesion with 1 to 2 millimeter margin if it is possible. Or other is if the tumor is so big and then desaucerizations or punch biopsy of that lesions are acceptable. But we really recommend not to do shape biopsy or the frozen section. You will know what's the reason in the coming slide, which I will explain more. Okay, so basically the first initial histology evaluations of that melanoma is very critical, not only for diagnosis, but also for the staging, which will greatly influence the patient management. So this is our pathology report. As you see here, this is for the biopsy specimen of the patient with melanoma. So as you see, we have multiple parameters which we include in our report. It's so these highlighted with the red asterisk are required element by CAP. And in addition, we put more parameter as you see here, which may be useful for the patient management. And here is I'm highlighting more parameter with the blue asterisk. That's the element required by AJCC. So some of the parameters are required by both AJCC and CAP. Some of them are just CAP requirement. And this is the pathology report, our pathology report for the surgical excision specimen, not biopsy. So it includes the skin ellipse as well as sentinel lymph node or the lymphadenectomy. So this is the page 1, right? We will report, is there any positivity in the lymph node and also any residual melanoma. This is first page. In the second page, we put the cancer template or the synoptic checklist. So the information here is not only from this current excision specimen, but also for the prior biopsy specimen of this patient. So we combine those two. Okay, so and then you will see here we are saying like this report include not only information from this current one, also the prior biopsy specimen, whatever number. And then we give the T staging and N staging. And most of the time we cannot give M or metastatic staging because that's mainly depend on the clinical parameter. But I will talk a lot more about it in the coming slides. So let me start with the AJCC. What is AJCC? American Joint Committee on Cancer, Staging and Classification. So TNN mean T for primary tumor, that means patient with only stage 1 and stage 2 disease, and N for the patient with regional metastasis or stage 3, and the last one, for the distant patient with distant metastasis or stage 4 disease. So TMN staging system is the basically main things that determine prognosis, treatments, and enrollment in clinical trial for those patients. So let me start with the T or primary tumor parameter. So T is mainly depend on the breast lobe thickness and the ulceration. Okay, so mitotic rate used to be the part of the criteria, but not anymore in the 8th edition. So let me talk a little bit more here. So for T staging, it's go from T1 to T4. And each T1, T2, T3, T4 staging, we have A and B, basically based on the presence or absence of ulceration. So if the tumor has the ulceration, is upgrade to B staging. But T1 is a little bit different, not only the ulceration, but also the tumor thickness. So T1 is basically 1 or less than 1 millimeter tumor thickness, right? So if the tumor has a 0.8 to 1 millimeter thickness, regardless of present or absence of ulceration, that will be T1B. But if the tumor thickness is less than 0.8, it can be stage T1A or T1B. And then the staging will change based on the presence of ulceration. So that's a little bit different. And also, sometimes we have to use TX, unfortunately. That's the specimen that we got very fragmented. So we have no way to measure the tumor thickness. So that's unfortunate scenario, and we cannot give this staging parameter for this patient. In those cases, that's why we recommend, please do the complete excisions or at least do the punch. That's where we can measure nicely the tumor thickness. And also T0 is sometimes the patient came as a metastatic disease with unknown primary. Yeah, that time we use that T0, okay? And the other thing in 8th edition is they promote the consistency in recording of tumor thickness. So they recommend rounding to the 1 decimal place. So what does that mean is, if you see here previously example, T2 is tumor with thickness 1.01 to 2.00. But if you rounded up to this 1 decimal place, it will become more than 1.0 or to 2.0. So that's the difference. And then second thing is that a little bit more significance. For example, if the patient has a melanoma that measures 0.95 millimeter versus the other patient with a tumor measuring 1.04 millimeter. But if we round them up to the 1 decimal place, both become 1 millimeter. So both are still T1B, not T2. Okay, so that's a little bit significant. The other thing is I want to talk about how to measure tumor thickness. So of course, we usually measure in dermatopathology in millimeter. So we use something called calibrated ocular micrometer. So using, basically we use that at the, and then we put at the right angle here to the adjacent normal skin. So this is the normal skin from the granular layer and all the way down to the deepest portions of the tumor. Okay, so that's how we measure the tumor thickness. So again, we use the calibrated ocular micrometer, and then we measure from the granular layer all the way down to the deepest tumor cells. And if the tumor is ulcerated like this one, we measure from the base of the ulceration to the deepest melanoma cells. And other scenario is, let's say, the tumor here, the tumor is extending all the way down to the deep margin. At that point, what we have to do is we measure the same way that we said before, but we report it at least in millimeter, of course, with the comment saying that if tumor is present at deep tissue, just more deeper invasion cannot rule out. That's the one of the reasons that we recommend please don't do the shape biopsy, okay? And I'm going to talk a little bit more about this potential pitfall in measurement of breast lobe thickness. I'm going to give you the example. So here we have a melanoma cell, invasive melanoma, of course, inside you here, as you see, and also we have few invasive melanoma cells. Some of them are here and some of them are there. Okay, so where should we measure? So apparently this one looks a little bit deeper if we see from the epidermis. So there are three possible ways to measure here, A or B or C way. So which way will be the best? So one thing is because this tumor is kind of close to this follicular. So if you want to measure this, you are supposed to measure from the middle of the follicle to here, like as the arrow, like this C yellow arrow. So if you want to measure, you're supposed to measure C instead of B. And on the other hand, you can measure this like A. So we will measure A and C, which is thicker. And whatever thicker one, we will use this as a breast lobe thickness for this patient. Okay, so the correct way is A or C, either one, whichever thicker. For this specific specimen, A is thicker than C. So we use A as a thickness. So the bottom line is do not include melanoma cell located in association with a nasal structure in the measurement of breast lobe thickness, okay? So periannexal melanoma cells are not included in the tumor thickness measurement. The next one. Here, this is kind of acral melanoma. We have some invasive melanoma cell here. We have ulceration here. Here is a big cluster of pigmented melanoma cells. So the question is, are we going to measure from the base of the ulceration to this cluster of melanoma cells, or are we going to measure from the granular layer to the thickest melanoma cells? So you can see B will be thicker than A, right? But the problem is B, this cluster is not the primary tumor. This is more satellite. But I will talk about the specific definitions of these microsatellite in the later part of my talk. So in bottom line, we don't include the microsatellite in the measurement of tumor thickness, okay? So the correct one is A, not B. Do not include satellite lesion, even it is present at the deeper portions of the. Also, the other thing is not only satellite, we don't include the lymphovascular invasion. Let's say you have a lymphovascular invasion here, you don't measure it, okay? And next one is the another pitfall. So when you look at this skin biopsy, it's a shape biopsy, and we have epidermis nicely, and then dermis is not so nice because you are seeing other features of epidermis in the middle of the specimen. So what happened is this skin tissue section is tangentially section. In those specimens, we cannot measure the tumor thickness accurately. So those cases, what you have to say is the tumor thickness cannot be measured accurately. And that's due to tangential sectioning. And next one is then tumor. So you see we have a big melanoma portion, the portion number one that I show the high power here, obviously very atypical melanocyte with the mitotic activity. So we know this is melanoma. On the other hand, we still have another cluster of melanocyte. Here is the high power highlighted showing that area, but compared to this one is much smaller less atypical. So actually this is the nevus cell. So this melanoma is basically melanoma arising from the pre-existing nevus. So even though the thickness here B will be much thicker than A, you are not supposed to include nevus cell associated with the melanoma in the measurement of breast lobe thickness. So the correct way of doing is that measuring this A. Okay. Next one is the multiple fragments. Sometimes we got multiple fragments of the tissue in the same bottle. So when we do it, as you see here, one of the fragments have epidermis and it doesn't have it, only at the periphery. So what happened is, first time the clinician get the shape biopsy, and then he or she found the additional pigmented lesion at the base of the first shape. So he or she take another scoop of the lesion at the bottom of the previous shave. That's how we get. So even though we relatively know this must be from the same lesion, but the bottom line, when you measure the breast lobe thickness, you have to measure in the fragment that's contain the with the epidermis. So basically BT1 for this case. You cannot combine BT1 and BT2 because you know this will be the base of this, right? Theoretically, you know, but practically you are not supposed to do that. So how you report it is that measure the BT1 and report it as at least. So basically, breast lobe thickness is not additive, okay? Next one. Another pitfall. So here you see the melanoma with regression, and here is the thick, deepest invasive melanoma cell. In addition to that, we have a little bit artificial clefting here, right? So the correct measurement of breast lobe thickness, of course, we measure from the granular layer to the deepest portion, but we have these artificial clefts. So you're supposed to subtract this thickness from what you get from B. So basically the correct way of measurement of breast lobe thickness in this case is the B minus A, okay? Okay, so let's move to next one. This is a little bit controversial, but what I'm going to say is what we do at MD Anderson. Let's say you have a melanoma, invasive, and you have the deepest invasive melanoma cell is here, and also you have the tumor with perineural invasion. And obviously this is thicker than the other one. So which one should we say? I already talked about this. We don't include the lymphovascular invasions or microsatellite in thickness. What about the perineural invasion? For this scenario, we give two types of breast lobe thickness. One is to the area of the deepest invasive melanoma cell. In this picture, it will be A. And we also give the another breast lobe thickness to the area of perineural invasion. So that's how we give two thickness for this patient, okay? So we do include measurement and we give two different breast lobe thickness. That way the clinician can get the idea how to proceed in terms of management. Next parameter I would like to discuss is ulceration. This is very important. So let's start with the microscopic definitions of the ulceration. We need to clearly understand what is the criteria to be called something as ulcerated melanoma. Okay, so microscopically, it's defined as an absence of intact epidermis. So the whole epidermis, the whole thickness of epidermis is gone. And then it has to have associated with serous crust, as you see here. Okay, but one thing keep in mind is it should be just associated with a tumor ulceration, not due to prior trauma or prior surgical procedure. That's another thing you have to keep in mind. So ulceration, as I said before, is very important prognostic factor because it can upgrade the tumor from A to B staging of any staging category T1 to T4, right? So for example, here, let's look at the T2B and T3B melanoma, T3A melanoma of the this is 10-year survival. So you see that a patient with T2B, that means that patient have the tumor is Breslow thickness of 1 to 2, and also with the ulceration. And T3 staging melanoma means the tumor thickness is 2 to 4 millimeter without ulceration, right? So, but when you see this graph, the survivor graph showing almost very similar. So what does that mean is survival rate of patient with ulcerated melanoma are similar to those of survival rate as next category. So for this one is next category will be T3 with no ulceration. So T2A very similar to T3A. So that's showing how ulceration is important in terms of prognosis for the patient. In addition, for the stage 1 and stage 2 melanoma, or another term is called early stage melanoma, if you look at the 10-year survival rate, if the tumor is not ulcerated, the 10-year survival rate is approximately 80%. But if the tumor is ulcerated, it dropped to 50%. So again, highlighting how important the ulceration as a prognostic factor in patients with melanoma. This is some of the potential pitfall in assessments of ulceration. So ulceration, I already mentioned the definition. So, but this one, for example, let's see. This is something that we call transepidermal eliminations of melanocyte, or another terminology is consumptions of epidermis, not the true ulceration because we don't have the serum crest, right? So the something like this is frequently called as ulceration. That's not a true one. Okay. The other one is just presence of scale crust. You see the epidermis is stay intact, right? We still have this strand and cornea. So this is not the true ulceration either. And the third scenario is sometimes we get the fragmented specimen. The epidermis should sometimes is detached from the rest of the specimen. That is just a detachment because the whole thickness of the epidermis is still intact. So this is no ulceration, okay? And the other common pitfall are incomplete section, right? Because in skin, sometimes we get the incomplete epidermis. So to see the whole epidermis, you might have to go for deeper levels to cut to see the whole epidermis. It's not the real, not the true ulceration. And the other scenario is the ulceration is due to prior trauma or due to biopsy, prior biopsy at that location, right? It's not the true melanoma associated ulceration. Okay. Let me move to mitotic index. So this is another thing. Most of the time we see a discrepancy when we review the outside submitted pathology cases. So to count the mitotic figure, first you have to look for the hotspot. So hotspots means so we kind of like in low power, we screen the whole session until we found a area with a possible highest number of mitotic activity. And then we have to count in 1 millimeter square area. So 1 millimeter square area, how can you calculate that? Actually, it varies from microscope to microscope. So you have to know and you have to calculate in your own microscope. For example, I have here, as you see, I have an Olympus microscope. For that 1 millimeter square is approximately equal to 4.5 high power field. So first I look for a hotspot area, at least I found 1 mitosis, and then I count continuously surrounding the area of that mitotic 4.5 high power field. And then we report it as a whole number, right? Like 5 or 6, not 5.5. And so in terms of the pitfall in this mitotic count counting is we are not supposed to average the mitotic count in 1 millimeter square area. So this is not average, the actual count. Okay. The second thing is make sure what you are counting is the dominant melanocyte. We don't count the junctional melanocyte. As you know, our skin is continuously regenerating. So you will see a lot of proliferative activity in the epidermis. So we don't count the junctional melanocyte for mitotic activity. We count only the melanocyte in the dermis. And another pitfall is sometimes you see the mitotic activity in the associated inflammatory cell or endothelial cell instead of melanoma cell. So be careful when you count it. And sometimes people use the Ki67 to count for mitotic activity. No. Reporting Ki67 positive cell as mitotic count is not correct. Okay. And other one is cutting additional session just to evaluate for mitosis. This is not necessary. You just count whatever session that you have. Don't need to go for more level to get it. Okay. Next one is the regression. Let me start with the definition because again, this is no well-defined definition, and usually we have a different approach. So the definition is replacement of melanoma cell in the dermis, okay, in the dermis, replace the melanoma cell in the dermis with fibrosis or vascular proliferation and or lymphovascular infiltrate, melanophages, and also the atrophic epidermis, basically loss of the Ricci ridges. Again, you don't need to have all these parameters to cause something regression. Of course, you want to have at least 2 to 3 criteria to fulfill the definitions of regression that I just mentioned. How to report that? You have to report focal or extensive. The cutoff is 75%. If it is more than 75, extensive. If less than that, it will be focal. Okay. Next one, perineural invasion. You look for it. If you don't find it, you report it as not identified. You found it and you report it as present. And then we also see that the caliber, the size of the diameter of the nerve fiber involved. Is that small, medium, or large? Because it will be useful for the decision of use of radiation therapy or not, okay? And then histology subtype. As you know, we have a different subtypes of melanoma based on the WHO classification. I'm going to show you the some of the common subtype. So let me start with the superficial spreading type. So it occurs in the intermittent sun exposed skin. It represents approximately 70% of total melanoma cases. So very common subtype. So it usually happens in the trunk of the male and the lower legs of the female. So definition, histology definition is to cause something is superficial spreading, you have to see at least 3 Ricci ridges with in situ melanoma beyond the invasive. So for this one, the invasive component stop here, and we have in situ component at least 3 Ricci ridges beyond this invasive component. This type is like mostly associated, it can frequently associated with persistent nevus, and it shows the high incidence of BRAF mutation. That's important parameter because that will help the patient eligibility for the anti-BRAF therapy, right? And another one is nodular melanoma. It represents up to 20% of melanoma cases. It's usually rapid onset, commonly pigmented, but approximately 5% can be amelanotic. That's a kind of pitfall because it's clinically, it can mimic like a pyogenic granuloma, okay? Histologically, it's kind of reverse of superficial spreading. What is this is the tumor usually shows some kind of shape circumscription as you see. And we don't have the invasive component beyond the dermal component, right? So the in situ component does not extend at least 3 Ricci ridges beyond the invasive component. So that we qualify for nodular. Next one is the lentigo maligna. It is present in the chronically sun exposed skin of the elderly individual, especially in the head and neck area. It's usually increase in size very slowly. Approximately 10% of melanoma represent lentigo maligna. So histologically, what you see is this confluent single melanocyte along the dermal epidermal junction and extension along the adnexal structure, as you see here in this figure. See, right, around the follicle. And they have a higher KIT mutation. Next one is the acral lentiginous melanoma. This is my research interest topic. But anyway, it is relatively uncommon, especially in the Caucasian patient. It's approximately 2 to 4% of all melanoma. So based on the location, it's usually happen on the sole, palm, or the nail buds. It's more common in Asian like us or the African American compared to the Caucasian. Then histologically, what you see is as shown in this figure, you see nest or single cell, as you see here, atypical melanocyte within the epidermis with extensive spaghettoid extension or migration. The subsets of these lesions also show KIT mutation as well as BRAF or NRAS mutation. So the last type that I am going to mention in this talk is the desmoplastic melanoma. It's also happened in the syndemic skin. So in low power, this is kind of a high chance of misdiagnosing this lesion. So the clue is in low power, what you see is this lymphoid aggregate. In the high power, you see these hypocellular spindle cell proliferation in the background or dense stroma. So these hypocellular spindle cells the approximate occupy at least more than 90% of invasive component to call is the desmoplastic melanoma. In another word is so-called pure desmoplastic melanoma. The other one, again, as you see here, still spindle cell, but the thing is, it is not hypocellular, right? Majority of the tumor cells are very hypercellular, even though spindle, and we don't have a dense background of these stroma as you see here. So those lesions is, we call it spindle cell melanoma with desmoplastic features. And also the other terminology is called mixed desmoplastic melanoma, not the pure. So the distinction is important because, as you see here in this table, so again, let me repeat this, pure desmoplastic melanoma means more than 90% of tumor with uniform desmoplastic stroma and hypocellular proliferation of spindle cell. If you have less than 90% of those cells in the tumor, it will be called mixed desmoplastic type or spindle cell melanoma with desmoplastic features. Why that is so important? Because for patients with pure desmoplastic melanoma, the rate of positive sentinel lymph node is much lower compared to mixed type of desmoplastic or other non-desmoplastic melanoma patient, right? So that's very important. So when you call something desmoplastic melanoma, the clinician might not even consider to do the sentinel lymph node because it is less likely to be positive, especially in the elderly patient, right? The risk is higher to do this lymph node dissection. Next one, important one is the lymphovascular invasion because first of all, I want to start with the definition, histology definition, presence of the tumor cell within the endothelial line lumen of vessel in intratumoral area or the peritumoral area or both. Doesn't have to be just intratumoral like in breast cancer. So be careful, the definition. Like this one, of course, you can make that interpretations of positive lymphovascular invasion on H&E. But as you know, the life is not that easy. Sometimes it's difficult. You cannot be sure. It's so suspicious you are not sure. Those times you can use the immunohistochemical study. So these are some of the paper from our group and myself. So we look at the immunohistochemical study and we found that the detection rate of lymphovascular invasion is can be increased by using the immunohistochemical study. Not only the rate increased, but also we found that lymphovascular invasion detected by immuno is significantly associated with other adverse clinical parameters such as ulceration, mitotic figure, thicker breast lobe thickness, and presence of positive sentinel lymph node. So that's important. And also, not only that, but also associated with decreased disease-specific survival in melanoma patients. So finding the positive lymphovascular invasion is very important. I'm just showing an example what we use. So if you use just D2,4-D alone, and this is brown color highlighting the vascular wall, and then most likely these are melanoma cells. But that the advantage of using the double immunostain with D2,4-D and MITF. Here, D2,4-D is red, highlighting the vascular wall, and then the melanoma cell inside this vessel is the highlighted with MITF. So we are sure this is the melanoma cell, not the histiocyte or other inflammatory cell or endothelial cell floating in the inside the vessel wall. So it's prevent the misinterpretation and they're more specific. Other parameters that are required to report PARCAP protocol are tumor size. Of course, that tumor size, we can only give one that tumor is grossly identified, right? So at least we have to give one greatest dimension. If you can, it will be better to give a 2-dimension. Again, the showing asterisk is not mandatory, but it's better or recommended. And another thing is if you see any macroscopic satellite nodule in your gross examination, we are supposed to report it. And as well as recommended to document if you see any gross pigmentation in that tumor. And also, we have to report the type of the procedure. Is it biopsy? Is that punch or excision? Does it include lymphadenopathy or the sentinel lymph node dissection? And also laterality of the specimen as well as location of the tumor. And in terms of margin, we report both deep and peripheral margin, both in situ and invasive component. If the tumor is present within 10 millimeter from the closest margin, we report the distance, specific distance in millimeter. For example, if the melanoma in situ is present 0.4 millimeter from the peripheral margin, that's how we report it instead of saying negative, okay? Okay, so this green asterisk, those parameters highlighted with green asterisk are recommended element, not the mandatory element to report. But we still report it because that can be useful for the patient management. So let me start with the Clark level. As you know, so Clark level, we have 5. 1 and 5 are kind of pretty easy. 1 is just the melanoma in situ, and 5 is tumor invading into the subcutaneous tissue. The other 3 are kind of a little bit confusing. So 2, 3, and 4. So 4 is tumor invading into the reticular dermis. So where is the papillary and where is the reticular? So we can draw a line, kind of imaginary line through the superficial lymphovascular plexus in the skin. So if it's the tumor, if below that line, that will be below that line but stay in the dermis, that will be level 4. If it's above that line, it will be 2 or 3. And 3 is like the tumor is completely expand and fill the whole papillary dermis. And 2 is just one of like very scattered cell here and they are not like fully expanding the papillary dermis. Another one is the radial or vertical growth phase. So radial growth phase is basically expansions of the tumor, mostly in the epidermis, kind of in situ component. On the other hand, vertical growth phase is for more invasive component. So for vertical growth phase, it can be qualified mitogenic or tumorigenic or both, either one or both. So mitogenic means if you have any mitotic activity in the dermal melanocyte, that will qualify to be positive vertical growth phase. And tumorigenic means if you have any nest of the dermal melanoma cell that is larger than the junctional melanocytic nest, that will be the tumorigenic positivity. So either one of these or both qualifying for vertical growth phase. Next one is the tumor infiltrating lymphocyte. So tails, basically. Again, we report this as not identifying or present. If it is present, we say it's a brisk or non-brisk. So what is brisk means? Brisk means lymphocyte diffusely infiltrate the entire base of the vertical growth phase or entire invasive component of the melanoma. Okay. Non-brisk, on the other hand, is lymphocyte just focally infiltrate the tumor. So that's the difference between brisk and non-brisk. And then associated nevus cell, that's another thing that we report. If we see the nevus cell, as you see here, we're trying to see what kind of nevus. Is that regular conventional nevus or dysplastic nevus? As well as we're trying to see what type of nevus, compound or junctional or the intradermal type. Another thing that we report is the predominant cytomorphology of the melanoma cell. Are they epithelioid? Are they spindle? Or are they kind of small nevoid melanoma cells? So based on those parameters, we get the staging of T staging. So next one I'm going to move is for the N staging for this synoptic checklist. Before that, let me talk about a little bit about management. Basically, all melanoma and any stage of melanoma, we get the white localization. The main thing is if the patient is going to get a sentinel lymph node biopsy or not. So T1A, so we don't usually do sentinel lymph node, but T1B and above, this is the criteria to go for the sentinel lymph node, or if it is already advanced, it will be the lymphadenectomy. So let's move to N staging. This is the patient with metastatic melanoma to the regional lymph node, or patient with melanoma metastatic to patient with a melanoma metastatic to regional lymphatic channel. That means in-transit met or satellite. I will talk about a little bit more about it. And then in terms of the staging, now we use the terminology of clinically occurred instead of saying microscopic, and the other one clinically detected instead of saying macroscopic. So let me start with this in-transit met or satellite. So microsatellite definition is microscopic for signs of metastatic melanoma in the skin or in the subcutis. It's usually located adjacent or deep to the primary melanoma. For example, this is the primary melanoma, and this is another focus, right? And that thing is completely, this microsatellite is completely separated from the primary melanoma by the normal dermis or normal subcutaneous tissue. There is no minimal side threshold or distance between these two, okay? Sometimes you have a primary melanoma up to here, and the possible satellite is right there, so close. You think if you cut deeper, they might connect each other. If you think so, please do deeper. If connect, of course, that's not the microsatellite. You just measure the thickness from all the way from there to here. Instead, if you have microsatellite, the thickness will be from here to there, plus presence of microsatellite. Okay, and let me talk about satellite and in-transit met. Not micro, so this is more clinical. So clinically evidenced dermal or subcutaneous metastatic melanoma. So those two are just difference in the distance from the primary tumor. So if it is less than 2 centimeters from the primary tumor, it is satellite, and more than 2 centimeters from the primary tumor, it is in-transit. And the other thing is both of them don't go beyond the nearest regional lymph node basin. For example, if I have a melanoma here, and then the satellite or in-transit shouldn't go beyond the nearest lymph node basin. That means axillary lymph node. So the satellite and in-transit has to be between this primary melanoma and this axillary, between this area, right? Not beyond the regional lymph node basin. So for N staging, we have N1, 2, and 3, and each one has A, B, and C. So A for every N1, 2, and 3 is basically number of clinically occurred lymph node positivity, and B staging is basically depend on the clinical, again, number. But A is the 1, and for B is you have to have 2 to 3 clinically occurred, or sorry, B is 2 to 3 clinically detectable. And C is a little bit different. C is mainly for the presence of the satellite, microsatellite, as I mentioned. So if the satellite or the microsatellite, if the patient have the satellite or microsatellite, even without any positive lymph node, the patient will give N1C staging. If patient has positive lymph node plus the presence of these in transit or satellite, depend on the number of positive lymph node, it will change. And one more criteria that we have to be careful when examine the lymph node, especially in growing, we have to look at is there any matted lymph node. That's only you can appreciate during growth examination. Because if you have a matted lymph node, the staging will change. As you see here, it can be N2, 3B or N3C. Okay, so that's important too. So just a summary. So not only the lymph node count, positive lymph node count, but also the presence of these non-nodal regional disease such as microsatellite or in transit, we categorize as N1C or N2C or N3C. Okay, and instead of saying microscopic or macroscopic positivity, now they say more clinically occurred positive lymph node or clinically detected lymph node. In terms of examinations of sentinel lymph node, so at MD Anderson, what we do it, if the sentinel lymph node is small enough, we kind of bisect it and then put on one slide. Or if the lymph node is big enough, we try to graft loaf it and put in the single paraffin block if possible. And the next session is when we get the H&E and we look at is this positive, of course we call it positive sentinel lymph node, but it is negative, we go next step. We get additional deeper H&E and two unstained slide. That one of the unstained slide is for pan-melanoma cocktail that include HMB45, MOD1, and thyroxinase. And after looking at that deeper and immuno, if positive, we go for it. And if it's negative, we just call it negative sentinel lymph node. This is the example of one of the metastatic melanoma, just one cell in the whole lymph node here, highlighted with pan-melanoma cocktail. And this representing the melanoma cell in H&E. So H&E alone, it is almost impossible to appreciate that. So according to AJCC, since 7 edition, even we see the isolated cell on immuno, it is qualified as a positive sentinel lymph node. But when we use the immuno, of course, we should be using the more specific melanocytic markers such as HMB or MOD1 instead of using like S100. This is, as you know, not specific for melanocyte or melanocytic lineage. And according to the AJCC, H&E confirmation is no longer required. As long as you see the positive cell in the immuno, you can call that as positive. But of course, personally, I prefer to see that cell on the H&E if possible, to see if that cell has malignant morphology or not. Next one is just a little bit about sentinel lymph node. So in terms of sentinel lymph node positivity, approximately 20% of patients has positive sentinel lymph node. And 50% of them have a tumor thickness more than 1 or more than 1 millimeter. And other 5% of so have the less than 1 millimeter. So that means T1 stage melanoma. And then 60% of those 20% of positive cases are detected on initial H&E. And another 5% of so are detected when the deeper H&E or the immunoslide. And less than 5% of those positive cases show extranodal extension. So in terms of lymph node, what parameter should we report in our pathology report? We report the number of sentinel lymph node, total number of lymph node examined. It could include both sentinel and non-sentinel, and then number of lymph node with metastasis, as well as matted lymph node, as I mentioned how important it was. And if we see the positive lymph node, we mention the size of the largest metastatic focus, as you see here, right? So we give the 2 dimension. But sometimes you can see this little multifocal positive cell. In those cases, we measure from one end to the other end because we assume that when we get deeper, all these focus will connect to each other. Other thing that we report is the location of that metastatic foci. Is the only subcapsular or intraparenchymal or both? And as well as, of course, we report any presence or absence or extracapsular extension. Okay. And this is the report, our report for the sentinel lymph node. Again, as I mentioned, how many lymph nodes are positive and largest tumor deposit, location of that tumor deposit in the lymph node, as well as the presence or absence of extracapsular invasion. So by doing that, we can get the end staging for our cancer template or the checklist. Okay. And this is a little bit for about interpretation in the in sentinel lymph node. So as I mentioned, if you do melan A for this case, now you are seeing there are at least like 6 possible staining here. So you are not sure if this is melanoma cells or is that macrophages. What you can do is you can do HMB45 additionally, and then you can see these macrophages will not be highlighted with HMB45. Okay. So just the example of that. Here is the sentinel lymph node from the patient with the thick melanoma. Here is the PAML. So usually we do the pan-melanoma cocktail stain, and we are seeing this, but we are not sure is a macrophage or melanoma cell. In that case, you can do HMB45 because in the macrophages, it will not stain. And other thing is you can do the SOX10. And one thing is what we did is we kind of destain the melanoma, this immunostain slide, and we use this for SOX10. And then see, SOX10 is, as you know, it should be nuclear staining. There's no nuclear, so altogether combined, we know this is not true melanoma cell. These are just macrophages, right? So the correct answer for this is macrophage. Other pitfall is the misinterpretations of capsula nevus as metastatic melanoma. As you see here, very thick capsula nevus, it's large, and this is highlighted with SOX10. So how can we differentiate the capsula nevus from metastatic melanoma? So the helpful features which favor capsula nevus is the location, right? Because it's called capsula, it should be intracapsular, not the subcapsular or intraparenchymal. The other thing is like comparing with the primary melanoma. The morphology is that small, should be smaller and should not show any cytology, it appear. And if you need it, you can do the HMB45 because HMB45 will show patchy or diffuse staining in melanoma cell, but relatively no staining in the nevus cell or capsular nevus cell. So another example here, now we are seeing here, this is the lymph node and here monotonous cell, not so big and some pigmentation. And then when you do the HMB45, now it's highlighting. So now we worry, this cannot be capsular nevus, even though the location looks like in the capsule. So, and then we did the Ki67, again, is highlighting the high proliferation rate. So altogether, this is the metastatic melanoma, not the capsular nevus. Another example here showing, this is very interesting case. Now you see, again, it's kind of capsular and a little bit of subcapsular, but these cells are relatively small compared to this or that, right? So we did the pan-melanoma cocktail as usual. Now you see the different staining pattern. This area is more patchy, but like this one and this one, those are more dense brown staining, right? Staining pattern is different. And also you can see location. These two are more kind of subcapsular. So basically, very interesting case, the metastatic melanoma cell located just adjacent to the capsular nevus. So this is the 2 component here for this patient. The last one is the M staging or distant metastasis. So it will depend on the distant lymph node, distant not regional. This is the lymph node, distant lymph node positivity, and metastasis in the skin and subcutaneous tissue and other visceral organ system, and also the presence or absence of increased LDH level clinically. So we have M1 through M1A through M1D. So basically, based on the anatomy location of the metastatic tumor. For example, 1A is metastatic to the distant skin, soft tissue. M1B is metastatic to the lung. M1C is metastatic to the central nervous system, visceral side. And M1D is metastatic to the central nervous system. And for each, we have 0 and 1 subcategory. So if the patient has the elevated LDH level, serum LDH level, that way upgrade the staging to 1 instead of 0. Okay, so this is just the example of brain met. Sorry, the light is off automatically. Next one. So in terms of the reporting of distant metastasis, pathologists should not report PNX or PN0. We should report as PNNA, okay? Because if we want to report as PM1, we have to see the distant metastasis under microscope, not the clinical information. So usually, most of the distant metastasis we know is from clinical or imaging report, not under microscope, right? When we are looking at the primary melanoma, we already know, oh, this patient already have the metastatic to brain or etc., but not under microscope. So we report what we see under microscope. If we don't know, if we don't see anything under microscope, we just say PNNA, okay? The other pitfall is that if we have two melanocytic lesion, malignant melanocytic lesion in the same patient. So is that the second one, is that the second primary or the metastatic from the previous melanoma? So again, nothing is perfect, but some of these features that favor the primary over metastatic include prominent in situ component, absence of lymphovascular invasion, and the presence of different area. That means morphologically different area. Some of the area might show more nevi and some show more epithelial, even though both are malignant. So if you have variability in the morphology, that favor more primary, okay? So this is just the every parameter that I mentioned in my talk. And in summary, so CAP cancer protocol template is required by most institutions, at least in US. And this is very important for the clinical management decision. Based on our experience reviewing the outside consultations of the referral cases, we still see a lot of discrepancy, mainly due to the unclear criteria or definitions of the each parameter. So it still need to be familiar with and understand clearly what's the definitions or criteria of each clinically and clinically relevant prognostic histopathologist parameter. And we recommend not to report not only the required element, but also the recommended elements, which may be useful for the patient management. And if you want to know more about this is a very nice review article written by your colleague, Dr. Trinidas, and she did a very good job. So that was a really great working together with her at that time. So thank you again for your attentions, and I will take the question in the break session if you have any. Thank you.